Good evening, everyone. Uh, on the behalf of Gulf Sleependo Lounge faculty, I would like to warmly welcome all of you to attend this 8th Gulf Sleependo Lounge meeting. Some of you may be wondering why this meeting is 8th and when this is the first time you are attending online. The reason is that previous 7 meetings we conducted as a round the table discussions in that we all sleep surgeon in a different subspecialty involved and discussing the complex OSA obstructive sleep apnea patients, and we are trying to implement the interdisciplinary management plan. So over the last 7 meeting, we come across a very uniform platform where the ENT surgeon, dentist, and maxillofacial surgeon and other expert could openly discuss the cases and share their opinion and learn from each other. So today, I can say mark as a very important milestone for all of us in our journey because we decided to open this platform widely for the audience so that the more clinicians, trainees, uh, some physicians, those who are interested in the snoring, obstructive sleep apnea, so they can participate, learn, and contribute in this meeting. So we are very much delighted to have all of us, all of you with us today. Thank you very much. So to start and begin with this, I'm gonna introduce our panelists and who have been very much instrumental in building and supporting this Sleep Endo Lounge initiative. Special thank to Professor Peter Baptista. So I will start with introduction of the Professor Peter Baptista. Basically is currently practicing in the Spain as a consultant ENT sleep apnea surgeon. He is internationally renowned, recognized sleep apnea surgeon, and he has exceptional contribution in the field of sleep apnea. I think everybody knows about it. He has documented many international journal publication, peer-reviewed journals, and last 2 decades, if I'm not wrong, every alternate research article related to the sleep apnea surgical thing, you can find his name. He has written multiple books on the sleep apnea and one of the finest visionary, I can say, and very well updated sleep surgeon in the world. To the add-on, just to heads up, he is a pioneer in only the series of the hypoglossal nerve stimulation, a revolutionary approach in the OSA patient. And I can say that he's a faculty for the sleep apnea faculties in the world. Now I would like to introduce our another professor, Dr. Hisham, from Bahrain. He is a prominent senior ear, nose, throat surgeon and a deputy commander at the King Hamad University Hospital in Bahrain. He specializes in advanced sinus surgeries, sleep surgery, complex head and neck surgery, and also he's associate professor at the Royal College Surgeons Ireland, Bahrain, and as a co-founder of the Vitality Medical and Sleep Disorder Center in Bahrain. The third faculty and the panelist is Dr. Jessica Schwart. She's a ENT specialist with advanced training in the sleep medicine and surgery in Venezuela, Chile, and Mexico. And she serves on the board of the Ibero-American Sleep Surgery Society. And she's an active member of ISSS and ESRS. She's an international speaker and faculty member, and she currently lead as a hypoglossal nerve stimulation program at American Hospital Dubai. And I can say very proudly, she's the first woman in the sleep surgeon in the Middle East. She has performed first hypoglossal nerve here. And beyond the professional, I can say she's a wonderful colleague and my friend. Our fourth panelist is Dr. Nicole Perez. Uh, she's a Mexican Spanish board certified otolaryngologist and specialist based in the UAE since 2011. She completed her education to the date with allergy and clinical immunology at the Foundation Geminis Das in Madrid, Spain. And she's a faculty member in the various conferences and workshops. Here I'm going to introduce my very good colleague and Dr. Ahmed Yasim Bhagat is a consultant ENT and sleep apnea surgeon with extensive international training and deep expertise in the managing snoring and obstructive sleep apnea. I can say the maximum fellowships are there on his name with from the different countries. He currently holding the position of the assistant professor in Alexandria University, Egypt, and practicing in Al Zahra Hospital as a consultant and head of the department. Dr. Bhagat is certified by the International Board of Sleep Disorder Breathing and European board certification. He is a wonderful teacher, very enthusiastic, and always ahead for the sleep surgery. And we are very fortunate today he is with us for this meeting. Next, absolutely a pleasure to introduce Dr. Tina Rukadia. Having been here in Dubai for 20 years, her practice focuses on the dental sleep medicine, airway focused dentistry. She's a qualified American Academy dental sleep medicine, and she has advanced expertise in the lingual phrenotomy, adult snoring, sleep apnea management, and the myofunctional therapy and early orthodontic treatment for children. She collaborates closely with the sleep surgeon during the dies. She's with a speech therapist, even with orthodontics. She also leads an airways study club, lectures at multidisciplinary conferences. She's leading a lot of podcasts and parents even across the ENT, audiology, dentistry, sleep surgery, etc., etc. Now, another professor is a highly qualified consultant, Dr. Muhammad Al-Ajmi from the Muscat, Oman. He's specializing in the snoring and obstructive sleep apnea. He did a fellowship in snoring and sleep apnea surgery from University of Bologna, Italy, with a Professor Claudio Vicini. He holds an Arab board certification and OMSB certification. He works at Gulf Specialized Hospital and Shifa Hospital, Oman. He's a very kind gentleman, but on the other hand, very knowledgeable surgeon. Last but not the least, the youngest, most dynamic consultant assistant professor, my dear colleague Dr. Ahmed Al Said, from the King Saudi University, Riyadh, Saudi. He specializes in the sleep apnea surgery. He earned his medical degree from the King Saudi University in 2014 and completed his residency from Dalhousie University, Canada in 2021. He has completed his comprehensive sleep surgery fellowship program from Stanford University in 2023. And to add on, he has extensive research experience in the sleep apnea. Currently, he serves as a evaluator for the Saudi Commission for Health Specialty, overseeing the classification and the specialization of the sleep apnea surgery, and he also leading some fellowship program over there. So I would like to thank you all of you for your continuous support, dedication, and commitment to advancing this medical education. Thank you very much. So from here, I would like to proceed further. To introduce myself, I'm Dr. Shailesh. So I'm practicing as a ENT and sleep apnea for the last 7 years, and recently I joined Tarabishi Healthcare Group. So I have a clinic in Dubai and Abu Dhabi and Al. So here I would like to go with this. So when we started this program, we had the original design of Sleep Gulf Endo Lounge, and then we decided to go ahead with the audience. So really very thankful for recreation of the version by Professor Hisham to come up with this new logo for us. And now we are come up with a short form of Gulf Sleependo Lounge Meeting, GSLE. Now before we proceed further, I just want to uh, give brief about what are the aims and agenda and objective of this lounge meeting. First of all, our aim is to collaborate the interdisciplinary board meeting in that not only the ENT surgeon, but also the dental, the pulmonologist and all other subspecialty will work into that. Another aim is that we promote the ethical case-based discussions, focus on the real patients, evidence-based, and try to implement the multidisciplinary management plan. And overall, our aim is to build up a strong sleep medicine community in all the across the region in the Middle East and in the Gulf region to learn more from each other and improve the patient care. And also, we are inviting a lot of new friends to join us from the Gulf region. Of course, we're gonna always discuss about what are the updates in upcoming sleep meetings which are around the region. So we are always encouraged to research some innovations in the sleep by sharing the experience, generating the ideas, fostering some collaborations. I can say that without the research, the sleep medicine is really lacking behind. So we have to really work on this research for that. And of course, so we need the guidance and suggestion from all the faculties, panelists, and the colleagues to understand much better. So overall, our vision is very simple. It's a quite a platform where we can just share our knowledge and ideas and discuss some scientific agenda. So before I proceed further, I would like to do some poll, basic question, just to understand what is our audience and how are they doing diets, are they involved in the sleep management and all. So my humble request to all our delicate audience, can you please answer these two questions? Are you doing a DISE routinely, that is a drug-induced sleep endoscopy, also you call it as a sleep endoscopy? And are you performing the sleep surgery without sleep endoscopy? So yeah, so we can wait for a couple of seconds so we can see are we what kind of audience are we dealing with so we can direct our discussion accordingly. I think the panelists cannot answer these questions because their expertise very well qualified. That is just for our audience.
I tried to cheat, didn't work.
You can't problem. I think can we have the uh, result of this poll? Right. Okay, so to all my panelists, so I think it's quite mixed answer. Almost one third, I can say that they are doing the diets very routinely. One third are not doing. Some are just doing as needed, and almost 15 to almost 50 to 20 of them are not doing diets. And yes, so almost 18% or 20% they said they are doing the some OSC surgery without DIAS finding, quite fair enough. And 50% are in the favor of DIAS. Okay, I think we can proceed further, analyst.
Yeah, go for it.
Yeah, right. Okay, so now here we go. That's what we can. It's a heart of our Sleep Endo Lounge meeting. We are learning to the real case presentation, and this is the case I'm gonna discuss with you. The overall aim of this case is not to make it very complex, like very advanced, and not something very basics. The aim of this case presentation is that everyone can involve in this, even from the junior colleague to all the ways to the senior. Very straightforward case, but it's quite complex. So many factors are there, not only just in terms of management of obstructive sleep apnea, just reading the polysomnography. Also, there is a process how we're gonna think about it and what are the factors we need to consider before we offer any surgical treatment. Right. So here we go. So this is a 29 years young gentleman. He's the Egyptian guy, single. BMI is 25. He's a hypothyroidism, taking the thyroxine supplement, no family history, non-smoker, non-alcoholic, physically very fit, doing workout very regularly. He presented to our clinic with a history of 3 to 4 months of snoring, choking, poor quality of the sleep, intermittent daytime sleepiness, morning headache is there. And he said that whenever he lie down on the left side, the symptoms are getting worse, not on the supine. So most of the time when we present, we see sleep apnea cases, they said when they lie down flat, the symptoms are getting worse. But he said specifically on the left lateral, the symptoms are getting worse. He's a bit anxious, a little bit restless gentleman, but he's not on any medication for that. Last 6 months, 3 months, he's using the Apple Watch and documenting he's having some apnea, poor quality of sleep that is make more anxious and all. But for some reason, for some snoring and some issue was that he did some sleep study and he said that was normal. I don't have any documentation for that. But last couple of months, the things are changing. He said he didn't put on too much weight and all. He started thyroid medication, I think 3 years before, as I remember. But on top of that, he's really concerned about the external appearance of the nose. He's planning for the rhinoplasty, but he said he will plan after resolution of his sleep-related breathing problem. But he want to address apnea first, and then he gonna go ahead with the rhinoplasty. So this is the gentleman. So I can say that you can have a look, front profile, side profile. You can look at the nose. You can have a look for the jaw. So for my panelists, just a quick thing. by looking his face, even Dr. Tina, Dr. Hisham, Dr. Al Said, Dr. Ahmed, is it nose and the big nose is responsible for me to give an impression that he's having a retrognathic chin, or really because of the retrognathic chin, his nose is more prominent? Any comment from your side?
Yeah, absolutely. That's a very good question. And actually, this is a fantastic case to showcase that. So, there are a lot of racial and ethnic differences as it relates to the development of the maxillomandibular complex. We don't really have normative data to tell us what is retrognathia or bimaxillary retrusion among different populations. But there are different methods to kind of try and get an idea of the development of the jaw in relationship to the facial aesthetics or the facial profile. Certainly nothing as it relates to the airway. One common method used in the aesthetic world is Andrew's analysis. So basically,
Mhm.
this guy is perfect. So he's in the Frankfurt horizontal plane. And for the audience who doesn't know like what the Frankfurt horizontal plane is, if you drew a line superior to the superior edge of the external auditory canal, parallel to the floor, keeping the head neutral, that would basically neutralize the position of the cervical spine. And then if you drew another line from the nasal bones or the edges of the nasal bone down to the gonion, basically the most prominent point just in the subnasally area or the most prominent point on the chin needs to fall on that line or beyond that line for males. For females, it's okay for it to be a little bit behind that line, slightly, um, especially from an aesthetic, perspective. As like how that relates to the airway is actually very difficult to quantify.
Okay.
But some people use lateral cephalograms and use like
Mhm.
numbers
Yeah.
as it relates to the slope of the skull base. So SNA and SMB. So if you triangulated 3 points, sella, nasion, and a point just that corresponds to subnasally on the X-ray, and another
Yeah.
point SMB that corresponds to the gonion on the X-ray, they should be like more than 80 to 90 degrees,
Yeah.
basically.
And Dr. Ahmed, I have another one or two slides in that. There is one cephalogram, so you can have a look in that, and you can put more comments on that one. Sure. All right, lovely. Any other comment on this, or shall I start or proceed further?
I would just say that from a dental
Yeah.
perspective,
Yes.
since this
Yes.
is
Please.
the what we look at, like I'm pretty sure that if we looked at his lateral cephalogram, which you're going to show us shortly, he would come out short on the mandibular retrognathism, like it would appear. And then at some point, it also comes down to lot looking at numbers. So
Hmm.
if I had to look at his face from an dentist viewpoint of view, I would say that's not a big nose, that's a smaller lower jaw and is likely to benefit in some fashion from, if this wasn't there. But let's continue the discussion.
Yeah. So why I'm putting this, because he's really concerned about the shape of the nose and he's planning for a rhinoplasty in the future. All right. So he did a sleep study on 22nd April 2026, level 1, outside the facility of mine. AHI is 48.5, RDI is 50, no central apnea. ODI is 36, lowest is saturation is 82, and saturation below 90 is 1.4. Classical symptoms of obstructive sleep apnea, AHI 48, it means he fall into the category of severe obstructive sleep apnea. If the AHI number, as per the definition, below 5 is considered as a normal, if it be 5 to 15 is considered as a mild, 15 to 30 moderate, and more than 30 is considered as a severe category. We all look all these parameters, and then after that, I came to know that he has seen oromaxillofacial surgeon in Dubai Health City, and they have done the X-ray and the CT scan. Right. So Dr. Al Said, Dr. Tina, Dr. Hisham, please ready. So yeah, that is his medical report. So this is presenter orthognathic surgery center, TMJ disorder, and they mentioned that airway volume is a 10K, minimum axial area is 36 mm square, average is 18 to 200. So anatomical findings are mouth breathing associated with the airway resistance and symptoms suggest you have breathing disorder. And patient condition is structural in nature and cannot be adequately corrected by conservative or non-surgical management. And the functional symptoms represent medically significant impairment, not a cosmetic concern. Any comment from the panelists on this X-ray and the medical report?
To be honest, I don't usually rely on lateral cephalograms or cone beam CT for the evaluation of the airway because honestly, these numbers, again, don't really mean a whole lot. We don't really know what is a normal airway, what size a normal airway is. Most of those images are usually done without any control parameters. So for these images to actually have any modicum of accuracy, the breathing patterns need to be controlled. So the airway size changes depending on the respiratory cycle, whether it's inspiration or expiration. Plus, this is a patient who's upright. So that doesn't necessarily represent what an airway is like when a patient is supine. Plus, sometimes you can't really control for mild rotation. So if the head, and we know this like from like assessing, deep space neck infections like retropharyngeal abscess or something. So if the images were a little bit rotated and they're not necessarily neutralized, that can change the size of the airway. And it's not just like, extension, flexion. It's also like, turning the head from one side to the other. So I would say it's very difficult to,
and unfortunately, I didn't have a full series of the images. I just got this much information from the patient. So I said, let me have a look into it. So,
I'm having puzzled a little bit with the history because it did say that this has been fine before the 3 months time, as far as I remember. So, and I believe he's been always retrognatic for life. So that's something to be bear in mind, like what's going on, what has changed. The other thing also regarding his polysomnogram that he had, I couldn't see if there was a positional mentioning about like whether it's position predominant or not. Was it mentioned?
I got just some medical report in that those funding was there, so I didn't get the proper polysomnography report with him. But on symptomatically, he said whenever he's lying down on a left lateral, his symptoms are getting worse. I think it's a non-positional OSA. Second, he did a sleep study 3 years before, means he had some kind of a snoring apnea story was going on. But overall, what I understand, Prof, I think last 3 to 4 months, his symptoms are getting worse. Before also, he had some snoring, but he was not much concerned. I think so.
Do we have
how
any
about his nose?
images? Sorry, about the nose, because I think the nose, I don't see the nose in the CT scan.
I agree.
or
I
not
about
mentioned.
to ask about the nose itself. Like, how does it look like on endoscopy, and like whether or not we have anything radiological as well.
Exactly.
So I'm gonna come up with my sleep endoscopy, so we'll have a look inside the nose. Right.
Thank you.
Yeah. Now, on the basis of this medical report, this is a little bit more jargon for me, honestly speaking. This is the lateral, cephalogram, and they offer him to go ahead with the bilateral bimaxillary advancement Lifford 1 osteotomy plus bilateral sagittal split osteotomy with a chin advancement to treat the above symptoms and improve functional breathing dynamics. And they are putting some cost and all these things, and they offer this surgical treatment for him. About the admission and also any comment about is this the right surgical plan? Even I want to do if any patient is having indication for this orthognathic surgery, is it the right description of this surgery?
Shailesh, what you mentioned is very interesting. I'm very attracted here because and that drags us to the whole idea of why are we gathering here? Because obviously we know that obstructive sleep apnea should be a multidisciplinary approach, and operating on X-rays rather than on the actual airway of the patient. I mean, if they are doing it for cosmetic, that's fine with me.
Wonderful point.
But like the rhinoplasty part, that's another issue. But if we're talking about the airway itself, you are subjecting him to that much of major surgery. That might improve his cosmesis, but whether or not it will improve his airway, that's another issue. So good that he came to you. I mean, I'm very happy.
I completely agree with Prof. Hisham. 100%. And this is almost like a reflex among a lot of surgeons, right? They treat anatomy. I would like to know more about his physiology. I would like to know more about dissect his sleep study a lot in a better fashion. What's his apnea index? What's his hypoxic burden? Is there, as Prof. Hisham mentioned, a positional component? What has changed? Making snapshot judgments based on limited pieces of information, whether it's an X-ray, an image, or even a single sleep study, is not necessarily the best course of action these days, right? So this is a person who I would actually like offer a drug-induced sleep endoscopy to understand his endotype much better, and I would repeat the sleep study because we have a negative sleep study, and then we have severe sleep apnea. So what has changed, as Prof. Hisham mentioned, in the 3 years since his first sleep study? So something is not adding up.
Yeah,
I agree with you guys. Now we change our protocol there here in Oman. Now nobody should go for any OSA surgery without DICE. So all of the patients should be evaluated by somebody who can do DICE. Now we have a team also from home office doctors and ENT doctors and even sleep medicine. Now it's here like an protocol after a sleep study and the patient failed CPAP, or if he's a good candidate for surgery, all the patient should go for DICE and should be evaluated at multidisciplinary team. Then we decide to do bone work or soft tissue work, or sometime we do combined soft tissue and bone. We start to do combined also surgeries with our colleagues of maxillofacial. I'm lucky here we have our maxillofacial in same hospital, and we are on the same team. So in such cases, I agree with you guys that we should not go and decide upon the X-ray or CT scan only. This patient should be have all evaluation with sleep study, with DICE, and of course general examination in the clinic, and take a careful history as well.
Yeah, I agree.
But I'm questioning the first sleep study, because here the first sleep study we didn't know how accurate that, but the second one is mentioned is level 1. So I will depend on the second sleep study, because we know some center they do level 3 and it's not a good machine sometime with no technicians, So I'm questioning the first sleep study actually on this patient.
Professor Peter, you want to say something?
I agree. I completely agree. I mean, I think there's a need to repeat the sleep study, and that will be the adequate thing. I mean, or to really get that sleep study and to be able to analyze it, actually. That will be the right way to look, because it's not a matter of anatomy. It's something else that's happening to him. Okay, and the AHI is, as we know, is completely not the right parameter, but he also has symptoms. So definitely we need to know what's happening. We need to know many other factors around it, and I completely agree with what has been said up to now. Completely.
And quick question. So for a comment to the Dr. Alajmi or Al Said, he's concerned about the rhinoplasty, and we are talking about the orthognathic surgery. So how you look at it? You guys do the rhinoplasty along with this, or how you gonna counsel the patient? So you do rhinoplasty first, then you do the orthognathic surgery, or you do orthognathic surgery first and then you go for the rhinoplasty? How you take it?
No, from an aesthetic standpoint, I usually do the MMA first, and then a year later I would do the rhinoplasty.
Okay, perfect.
Because like when you advance the maxilla, that will drop his tip a little bit further, especially in someone with a very long nose. He will have a droopy tip, even with a counterclockwise rotation. So I would wait. So I would do the MMA first, address his airway, and then do the rhinoplasty a year later.
So any other comment? Or
I agree with Prof. Ahmed. We do same here. We do bone first, then we do rhinoplasty after that.
Perfect. So I'm gonna go ahead further. All right. So, considering he's having a level 1 sleep study showing a severe apnea, he visited pulmonologist in Dubai to discuss the sleep studies and all. As narrated by patient to me, he tried a CPAP, but he's not able to tolerate it. He doesn't want that. So of course he referred to me for the second opinion before or for the MMA surgery. He was about to go for that one. And I gone through the history and all. He never visited any ENT surgeon before. And on the clinical examination, I've seen that he has a maxillary crest with a deviated septum to the left side. He has a grade 3 terminate. Friedman tongue position is 2. He has a grade 1 tongue tie, right? He has a grade 3 tonsils. He has an elongated bulky uvula, pretty long bulk, thick neck. And he also underwent a CT scan. I just have one image. So I think it gives me an impression that he has also slightly high arch palate. That is something in the middle of the way. But he has a maxillary crest, deviated septum, quite big and large tonsil. We can have a little bit better look in the endoscopy. And to note that here, I can say he has a grade 1 tongue tie. Proud. So guys, let me see. Are you guys gonna share the computers on? Yes.
Shailesh, as you share it, one question. Any history of recurrent tonsillitis in childhood or later on?
He mentioned that during childhoods. No comment on that. So nothing like a recurrent tonsillitis. But he said he falls sick. He doesn't like to drink, cold stuff and all. When I ask, leading question like you, so he mentioned about that. My throat is always sensitive, but is it just grow right now recently? I said no, it is not just. It must be there since your childhood. But he didn't put any specific question. Only he said. I fall sick frequently, but not that known. Nobody mentioned he has a big tonsils.
The only thing I'm mentioning this because, like, at times I've seen patients who had infectious mononucleosis. Their tonsils can just explode and go very huge, and it stays like that. So that's why I was thinking whether or not that what he's gone through later on. If it's not like recurrent tonsillitis early in life, maybe that what he had that has changed the nature of his pathology. But that's just like grade sort of imagination, maybe.
All right. Interesting point.
Actually, I would like to add to that because I had a patient not that long ago, a female patient, roughly the same age, who had a slight increase in her tonsils. And then, for some reason, she was like fatigued, just incredibly fatigued. She also had sleep apnea. Something was off about her, so I ordered a CT scan with contrast. Turns out she had multiple lymph nodes, and then ultimately, when we sent the tonsils out during the UPPP, it came back as lymphoma.
Oh,
yeah.
So I'm in accordance with that. That has happened to me quite a few times, at least 3 times. So that is something that should be looked into, definitely.
So what I understand, if there is no classical history of recurrent tonsillitis in the childhood and all, or something we saw the huge tonsils and we are planning for any surgical treatment for the patient, better we send tonsil for histopathology, or we should do the peripheral smear and all to make sure we are not missing any morphology.
Shailesh, one more thing before you proceed. Sorry, and for the held here. You mentioned also that the patient went to a pulmonologist, and he was after going to a MaxFax, and he was never seen by an ENT, and he was prescribed a CPAP, and that also breaks my heart again. That shows the amount of
That's why I put a very straightforward leading question to him. But fortunately, pulmonologist referred to me. He was trying to use the nasal mask, not the full mask. And he said he never saw any ENT doctor because when I saw his throat, huge tonsils in the mouth, I said, it's okay. So let me see how I'm gonna lead. But I offer him, I said, you already, somebody offer MMA surgery, you're going for that. You don't want a CPAP. I think better let's do the sleep endoscopy to see what exactly happening with you. So he also asked me, doctor, can you remove my tonsils? I said, it's a very tricky question for me. Shall I just remove your tonsils? Because I don't know what I'm dealing with. So that's why the sleep endoscopy is here. So can we play now?
100%.
Right. So can you hear? Is it audible to you?
Yes.
Perfect. So that's on the left side. I'm going to put some live commentary. So you can see there is a maxillary crest, quite significant blockage on the left. I'm going from the right. He was keep talking to me. Oh, sorry. just to add on to all my audience, so even this recording is around 8 minutes time, but I do sleep endoscopy for half an hour to 45 minutes on an average. And we have to wait in between the maneuvers and all for the patient to fall asleep. And then we see some 1 or 2 episodes of the snoring apnea and when do examination. Sometimes patient mumble, sometimes patient wake up. I always allow my anesthetist to lead my sleep endoscopy unless they said, now, Shailesh, you go ahead. Then I put the endoscope because most of the time we put the endoscope, patient wakes up. I do not spray the lignocaine. I do not put the Otrivin anything. I just put some lignocaine gel in the front of the vestibule. Sometimes those who are really sensitive on a sneeze. Otherwise, I don't put anything. But definitely, we try to give some glycopyrrolate if those to reduce some secretions and all. All right. For that, okay. So that is the left nostril. If you see my arrow, that's a pulse, that's a saturation, that's a blood pressure. We see the big spectral index, we see this depth of sedation. So I'm in the nasopharynx, and that's from the retropalatal space. You can see there are two domes. These are basically the big tonsils, and that's the palate. They are exophytic tonsil. I think you have seen the uvula popping up. Posterior pharyngeal wall is pretty much flat. Mucosa is not that redundant. Literally, the tonsils are touching the posterior pharyngeal wall. Now it's slowly going into the apnea. Then he does the rescue breathing. That's the uvula, the expiration. Yeah. Whenever the uvula is stuck in between the tonsils, he choke more. Now it's kind of apnea, saturation dropping down to 87. As per the sleep study, it goes to around 88, 86, I think so. Now I think he's breathing through the mouth. But if you can see the efforts are there, he must have a lot of arousal. Inspiratory. I really struggle to pass my endoscope in between the tonsils. Now you're gonna have a look at the brainstem, pretty good. We don't see any linear tonsil. Epiglottis, I can say, is a normal shape. Plus the epiglottis fold is also pretty much good. No as such collapse at the level of base tongue and epiglottis. I did the Ismerch maneuver. Just a heads up, for the Ismerch maneuver, we always ask patient to move the jaw forward and backward to see how much he can able to move. In that, we try to move the jaw forward around 70% of the calculation, not more than that. Right. And then we try to see that is there any change in the collapsibility at the level of velum? Means it's a secondary, or also we look at base of the tongue. So now we are doing the Ismerch. The snoring factor slightly lower down. You can see the base tongue epiglottis is sitting absolutely fine the way it was, but much better way because I move a jaw a bit forward. But even without Ismerch, the base tongue epiglottis was pretty much stable. Now I release it, again I start choking. Of course, it never happened immediately. It takes a couple of, 30 seconds to 1 minute time for the airway to slowly collapse and start choking. Then I turn patient to the left lateral. When I turned him to the left lateral, I remember that he was feeling he was choked when he's sleeping on the left lateral. He has more symptoms, more badly. And I'm seeing his tonsils are slipping at the base tongue and literally is touching the epiglottis. And his tonsil is trying to push his epiglottis a little bit. That's his right tonsils. They are literally getting folded and overlap each other in the left lateral. And it's trying to squeeze his epiglottis with the lateral pharyngeal wall. Now I gave him a Ishmarch in the left lateral. So of course it stabilizes the base tongue and epiglottis. Tonsils is slightly pull forward a bit, but still I can see it is sitting in the base of the tongue area. Now I release it. You can see the gigantic tonsil there. Now this is called as tongue palate interaction. I slowly pass camera through the mouth to look for how the palate having a connection with the base of the tongue. Either the base tongue is pushing the palate. You can see during inspiration in the fold of the base tongue, the uvula is get pulled and that snore along with the tonsils. So by seeing his uvula and all, he must have a snoring problem for a long time. You see, the base tongue epiglottis is pretty much in a better shape. Try to pull his jaw forward. Of course, it stabilizes the base tongue and epiglottis when we pull the jaw. That is Ishmarch. That is his right and left tonsils. So that's the left tonsils. That is the uvula. You can see my pointer. Tongue is pretty much stable. It's slightly move backward, but it doesn't look like it's collapsing. That's his uvula. You can see in the midline. On the left side, the recording purpose. Hey, so that is the sleep endoscopy for this patient. I've tried to explain the findings, but anything I missed in this sleep endoscopy, which I didn't register, or any comment from the panelists,
Yes,
Nicole,
can I
Jesse,
comment?
Hisham, anything?
Yeah,
Anyone?
Well, the tonsils are driving me crazy. The tonsils are driving me crazy, as well as the uvula, and it gets my attention because it's very interesting how this patient can get to this point, because I don't think it's something is happening like since 3 years ago, you know. I think this is something happening probably since childhood because of this vertical plate. He doesn't have a right tongue coupling with the palate, and also these huge tonsils are generating this important obstruction from the lateral point. So, of course, I think that is the first thing we need to correct. But my point is, it's very interesting to see how this patient gets to this point without an ENT evaluation. This is crazy.
Right.
And
I want to
the
also...
the other insight is that we do need the sleep endoscopy. We couldn't have all this perspective of the dynamic of the airway without seeing this. So this is beautiful because I think it's extremely graphic how we can have an idea of what's going on with these dynamics while sleeping now.
So any other comments? Anything, Dr. Ahmed?
Yes, Sharish, because
yes.
How many of you, after this case, and you do tonsillectomy, and you find that your patient is not improving? Because I did some of them. I was very happy to remove those big tonsils and uvula to make them shorter and do pharyngoplasty. And actually, I find after that, some people even got worse. So I don't know, but if maybe the tonsil maybe can prevent the tongue base from collapsing. And even when you remove these big tonsils, you find the tongue has more room to collapse more,
Honestly,
what happens?
I agree.
What happens when you did the S-march maneuver and you advance the mandible forward, the tongue is moving forward, and the tonsils are still big and there, and they are no more collapsing. Yeah. So I think this just simple test during the dive when you advance the mandible and you find that the airway is open at the level of the palate. So that means that the palatal collapse, whatever the tonsil or uvula or the soft palate, are collapsing secondary to tongue base collapse. Do you agree?
But at the sleep endoscopy, yes, we got some impression that by pulling the jaw forward, the airway is slightly open. It stabilizes the tongue base. But if I see that, his tonsils and palate start collapsing again, it doesn't collapse that badly, but it is not something completely stabilizes. Dr. Ahmad, he keeps snoring slowly, but the intensity of the snoring dropped down. So, yeah. So jaw movement advancement, it is not completely improve his retropalatal collapse or the oropharyngeal, I can say, tonsil collapse. Just to add on that comment from my side.
I would add to Dr. Ahmed Bahjat's comment as well. So I have a number of patients just like this where I failed. So I would take the tonsils out and they actually don't do very well.
Even got worse.
Some of them actually got worse. So I completely agree. I think that there are two types of patients. So one of them could be, the poor tone, just I don't know, just like very weak muscles kind of patient. Yeah, and the other honestly is more kind of just scrutinizing the sleep study. So you've got a lot of those like low arousal threshold hypopnics who they just don't do well with any kind of surgery. And usually those are the two types of patients, and they're usually around this kind of age group, and they often have multiple factors, including bimaxillary retrusion. So they are very difficult to treat. Honestly, very, very difficult to treat.
May I comment? Okay. So when I'm in accordance with Dr. Ahmed Al-Sayed about what he has mentioned. However, and also it's true, Dr. Ahmed Magat, but I do think, okay, from a straight point of view, at this moment, what we're seeing, he does have a severe obstruction of the airway that's produced by the tonsils. This obstruction he has a difficulty. The poor person is really struggling to breathe at this moment, and his tonsils are collapsing completely. So doing a tonsillectomy might improve him completely. I'm not in accordance completely with what Dr. Jessica said that it's long-standing. I do think that maybe he had this for a short period of time, maybe his tonsils have grown, and that's why a biopsy of the tonsils should be performed. Okay. Now the question is, would you do a palatopharyngoplasty with the tonsils at the same time, or just do tonsillectomy?
Yeah.
Okay. That's the next question that will come up.
Yeah, I'm gonna put it those things. So
Right.
just to summarize, so he's a young gentleman. He's a concern about the cosmetic look of his nose. He want to do some rhinoplasty in the future. He's having hypothyroidism, some anxiety, recent history, little bit controversial, severe OSA, right? So of course, whenever we are looking at the AHI more than 30, we are directly straightforward say that as per the guidelines CPAP, but intolerance, and he's refused to use that one. As per the DICE, is very common things come in your mind. Let's do the nose and palate. So my question is that you guys do both nose and palate all together, or you always, stage the procedure? Any one or two quick comment on?
Before reaching that, let me ask you, would you go and do dice alone and then decide on what to do, whether it's nose or combined, or it's like one with something? The reason I'm saying this, like in such a patient, I think what I'll do is doing the dice and the nose, because definitely, I mean, I'm talking, when I say the nose, I'm talking about like turbinate septum. I'm not talking about the cosmetic aspect here, of course. And then I'll sit down together with him, show him the video, discuss it, and then come up with the decision regarding the other levels, because that's granted. I mean, yeah.
So you mean to say, Professor Hisham, you do the DIAS and immediately in the same sitting, you're going to perform nose surgery?
That's correct, yeah. I'm not talking about this patient. I'm in
Yes.
general, the patient has got some nasal complaints, because to me, that's like static obstruction that can add to other parts and actually can influence the rest. So I would do that. I would do the dice, keep the patient informed about the situation, and then decide on the next levels. And
yeah,
interestingly enough, I've seen some cases whereby they do improve nicely and dramatically after doing only the nose, despite, in contradiction to some of the findings that I'm seeing on the dice, especially when you talk about the base of tongue, interestingly enough.
But Prof, my question to all of them, he's really concerned about the external appearance of the nose. In this case also, we guys routinely offer the functional nose surgery, or you want to go offer him proper functional rhinoplasty with a turbinoplasty?
If the question to me, Prof, what I'll do seriously, because to me here, it's a twisted case to an extent. The only reason behind it is that if I'm gonna do the septum and he wants to do a rhinoplasty, then I would do it at the same time, because I'm gonna utilize the cartilage to reconstruct. Yes. Otherwise, I'll lose it. So here it's a bit of a twist, because also we spoke about whether to do the maxfac surgery before that. I mean, ignoring the tonsils and the dice findings here, I'm just talking about the whole idea behind it. So I think, yeah. Sorry.
But how that's I put a palatoplasty, but my question is that about he already offer a max for surgery. So young gentleman concerned about the cosmetic look. On the endoscopy, we find that he has a huge tonsils, he has a deviated septum. How we can say it's appropriate to go ahead with the MMA followed by rhinoplasty, or I can put it across why we should not simply do the septoturbinoplasty with tonsillectomy. Of course, we can add palatoplasty because he has a huge uvula. It's a soft tissue surgery. In the worst scenario, I can say what will happen, his AHI may not improve, but snoring expected there will be improvement. Then we can consider with the MMA. How we gonna put it? To open to everyone.
I think in this case, I would twist the whole thing. So I would do the tonsils plus minus palate, and then do the maxfacs, and then the nose. Only in this case, because of like the cosmetic aspect involved.
And how long you gonna wait in between your palatoplasty or any surgery and rhinoplasty? 6 months, 9 months? How have you gonna frame it?
Well, because the maxfacs will be before that, right? So I'll push this to Prof. Ahmed.
Yeah. Yes, please
I want
comment.
to mention something that I think it's very important that I spotted on this patient. We have to consider that he has some few red flags. That is a single, male, anxious, and very concerned about his appearance. Yeah.
Absolutely.
So this is, he doesn't care about the choking and having, he's almost dying when he's sleeping with that has severe sleep apnea, and he only cares about his cosmetic nose and so I think we have to be very careful with the patient selection, because this
Absolutely.
seems like a patient that is going to give you a headache whatever you do first.
Yeah.
I think I will send him first to a psychologist, and then we need to warn him, because any surgery you will do, he will be unsatisfied, unhappy. If he so I This is, I think, something very important, and you need to have clear communication with him and put him in a ground all the expectations, because you can do an amazing rhinoplasty, and he, I think he sounds like he's going to be unhappy. So yeah, this is a question, because he might, and then he's already jumping from doctor to doctor. So this is a few red flags that I think we cannot ignore, besides the sleep medicine, like the basic medicine.
My question to thank you. You want to say something, Nicole? More?
No, that's it.
Yeah.
That's it.
Hey, my question to Tina. Dr. Tina,
Yes,
are you
I'm
there?
here. Yeah.
Hey, if I go a little bit more conservatively, suppose I have done septoturbinoplasty and I did some tonsil palate surgery. How you look at it, the patient, is there any role of oral appliances, MAD, tongue tie release before we go ahead with the MMA or something? Do you think so? There is any room for dental point of view in this case?
Right. So
Anything?
thank you for the question, Dr. Shailesh. And it's really nice to be able to hear, both viewpoints on this constantly. So like we saw from his facial structure, that retrognathic mandible, then you also added to the picture with saying that there is a tongue tie.
Yeah.
Below the tonsils, we saw the tongue base collapse as well. So that does look like a crowded velopharyngeal and post retroglossal space as well. So if this patient was, let's put aside the ideas of his actual complaints are probably more aesthetic, but there are, like, as dentists, we see patients who are usually not happy to jump into palatopharyngoplasties or U triple Ps, etc., even though over here he really showed collapse in that area as well. But, I would try and, like, at least definitely convince this patient about the nasal procedures, because nothing's better than nasal breathing. If, you guys were okay with the tonsil removal, then we did see improvement with the Ismach maneuver. Now, while we see improvement with the Ismach maneuver, it always, the thought in my head is, how is this patient then going to do with myofunctional therapy and better tongue placement? So what we usually miss out in our ENT discussions becomes, what is the arch space like? Is there going to be enough tongue space? What is the tongue tone like? Is there a tongue tie? And this is an aspect that the team from Dr. Baptista's team in Spain has put out some lovely research earlier this year, talking about how they saw improvement in tongue-based collapse on these patients just from myofunctional therapy procedures. So if the patient was not keen on a UPPP or a palatopharyngoplasty, this could be a nice combination of, let's get nasal breathing, get out the structural aspect of the tonsils out, and then see the improvement from myofunctional along with a MAD.
Right. A quick comment. Do you think so? If we do the nose and some tonsils, can we avoid MMA by just giving the oral appliances? As Ishmar shows, there is improvement. Any comment from anyone? Could it be possible?
I think that would be possible. I wouldn't offer any kind of surgery on this patient. So there are a number of things like why I would do that. Number one, DICE is not natural sleep. So I would, what I would use in terms of like the findings that I see on DICE, I would use that more for prognostication than using it as a diagnostic tool. So we've seen some improvement with the S mark. Nobody has ever really had any major complications from a mandibular advancement device. Just start there and see where that goes. I wouldn't necessarily also discount mandibular advancement devices in someone with severe OSA, especially if they were retrognathic. Let them have a go at it. So I would do that.
Oh, I will add to that to say, while I can't find great teams here in Dubai for, the sleep and orthognathic surgery combination, and it is also hard to convince patients to have MMA, but the patients who actually come in wanting that aesthetic change along with the MMA will always say this could be a cure for my OSA versus a MAD is going to be management for my OSA. And since I'm young now, you're going to tell me 10 years later that I can't have this procedure because of age. So that is where, the conversations go to, but it comes down also to the patient in front of you as well as you as a person around those possible complications. So thank you, Dr. Ahmed. I'm in agreement with you about the MAD.
I have two last comments on this. Number one, in case he land up with the MMA surgery, what could be the outcome we could expect with this kind of a finding of a huge tonsils and nose? Could we expect there is gonna be some improvement with the MMA surgery?
Most
Assumption
likely,
he just
he will improve. The only thing is, I don't think he'll be satisfied.
okay,
Um,
satisfaction problem.
yeah,
Okay.
that's the main thing. So, like the problem before, like actually committing to a large surgery, as Dr. Nicole said, this guy has so many different red flags, right? I would be very careful. I would be very conservative. I would try to understand what exactly is going on. Try to define the goals of treatment. Also, set expectations very well. And I find that it's easier to actually operate on a patient who has had a very long journey, trying out different things and not having a good outcome, than operating on a patient even if they had an excellent outcome but they're not necessarily convinced, because a lot of sleep is about perception, right? You might run into trouble if they're not happy, like if you operated right away.
Wonderful, wonderful, wonderful comment. All right. Any other concluding statement from Professor Peter, Dr. Ahmad, Al-Chami? Anyone last comment on this?
I think you put a question here regarding like whether or not like you are proceeding with the tonsils and the uvula. Are you gonna do barbed stitch at the same time or not? I think that's interesting because I would love to hear your answer before I do answer it. It's a bit tricky, right? Because thinking, let's say in general, that you are removing the mechanical obstruction, so logically, if patients should improve. But then how about the, let's say, dynamics subsequently that, like, if the lateral wall of the tonsillar fossa is collapsing after removing that stenting effect of the tonsils, huge tonsils. So he might still end having the same problem. So would you do the same? Like, would you go for barbed stitch or not? That would be interesting.
For my school of thought, professor, for this kind of patients, after removal of the tonsil, I don't leave the palate as it is, because I preferably there is no harm to put the PDS 30 through the palate to make it stiff. And also, I'm gonna trim some mucosa over the uvula. I don't cut uvulas, but I'll go through the barb suture through the uvula and pull it up toward the nasospine. So I try to make the palate a little bit stiff. But in this kind of a situation, I usually don't cut or release the palatopharyngeal muscles. Overall aim is to just stiffen the palate. That's how I look at it. Any other comment or anything correct me?
For me, I do same, Shalat. Actually, I remove the tonsils. I do barbed pharyngoplasty at the same time with pulling the uvula. I try to preserve mucosa as much as I can. Sometimes I trim the uvula if it is very long. And if you ask me to do nose and palate together, usually I'm not doing like Dr. Prof. Hisham. We do a dice on endoscopic room, not on the OT. So I do dice alone without nasal surgery as the initial step. So because we do it in endoscopic room, not on the theaters. That's it. So after that, usually I do nose and tonsils pharyngoplasty all together. But this patient, of course, is a special case. He's concerned about cosmetic as well. So here the issue is different. But usually I do it all together.
Right. So here I'm gonna conclude the discussion. All right. So I'm gonna go ahead with the next. Here, Dr. Tina is gonna lead our today's meeting. She's gonna talk about SAM and DICE. You guys are listening from me about the Ishmael maneuver, jaw thrust, but there is something we need to highlight more. So I'm gonna stop my sharing, Dr. Tina, and please share your slides and please go through it.
I've just sent a request for the share. Okay, got it.
Okay.
Let me know if you can see my.
We can see.
Okay, give me.
Yeah,
okay.
You can't. Perfect. Can
Yes,
we
we
do
can
the
see.
presentation mode, Dr. Tina, for us?
Okay,
Right.
let's go. All right. So this is just
Yeah,
like
lovely.
a quick 5 minutes, just as an introduction on, what we're being able to do beautifully in the team in Dubai. And that's especially thanks to Dr. Peter Baptista for introducing me to this. So I'll pay homage to my Indian roots and say that, Airway really is a team sport, and no one specialty can really solve it alone. And we need to, allow different people to have their viewpoints and their opinions on it. And I really do appreciate that DICE is quite the meeting point with giving us this real-time functional diagnosis, even with all the negatives around it, that it's probably not true sleep, it probably has further muscle relaxation, but it's the closest that we can come to not shooting arrows in the dark. A quick one on oral appliance therapy. As most ENTs know, but there's lesser faith in believing that the MADs are actually a good addition to sleep surgery as a complement to it. It doesn't need to be an either or, but they, of course, increase the upper airway space, also advance the tongue, stabilize the hyoid bone. But we do see that we have mixed outcomes. And then in some cases, they actually can lead to worsening of the baseline condition. And in others, while it can be a combination, like Dr. Ahmed said earlier, there are sometimes cases where just in severe OSA, also just a MAD can be sufficient. So what we found is that the variation in stability in improvement goes from 30% to 81% in the effectiveness. Different studies say they work in less severe or only in supine OSA. Others say, works in non-positional, doesn't work with females. So, we're seeing all kinds of different answers come about it. And it's challenging. So if your patient goes just to the dentist, how do we really know whether we should do the MAD? Is this going to be enough or not? Coming to if the patient comes just to the ENT. So Dr. Shailesh brought about a great point that he tries to evaluate this with, saying what is the advancement in before the patient is actually in the DICE. But I can confidently say that not many ENTs are comfortable asking patients about the protrusion, understanding jaw tension as the patient is protruding clinically. And I, for one, wouldn't know what is 70% of advancement when that patient is asleep during the DICE. So the jaw thrust could be 100%. The jaw thrust may be less than 70%. It may not be stable to hold it in one place. Additionally, we're not introducing a vertical component. So, because of all these variability in the process, it was a really brilliant idea by this lovely doctor in Madrid, Spain, Dr. Patricia, who invented this appliance called the SAM Mass, or the Selector Advanced Mandibular. And it is really as simple as this. For a dentist, this is like everyday armamentarium, where it's got an upper tray and a lower tray that I've got a little, this is all we actually need, the endoscopes that you guys use during the DICE, as well as this armamentarium. I've got a short video here showing you what we do with it before we actually go into the OT with our ENT. So I'm placing it in the patient's mouth. I've taken the upper impression first, the lower impression later. And now I'm marking out what is his maximum advancement and his maximum retrusion. So I will forward a little in the interest of time. And you'll see that we asked him to protrude the most that he could. I have kind of marked that as maximum protrusion. And then similarly, I will go on to mark maximum retrusion. And once I have that gap between the two white markers advanced, as I place this in the patient's mouth during the DICE, I'm able to freely decide between how much protrusion I want to evaluate with my ENT doing the endoscopy. So There is a lot of research put out by the team with Dr. Patricia around it in a protocol, which helps us actually understand how to do the DICE with the SAM. But in a really small crux, we would say that they check without the SAM, so just in normal sleep, and then they check at 50%, 75%, and 100% of advancement. And they're checking for a valid response. So the valid would count as 3 minutes without apnea, as well as controlled oxygen saturation. And then they also check this in the lateral position around it. So I'm keeping this really short and simple as an introduction. The rest of the presentation goes a lot into myofunctional therapy, which can also be, as we said, discussed with tongue-based collapse during DICE studies. But a big thank you, Dr. Shailesh. I don't have a picture with you over here, so we need to change that.
Thank you.
All
right.
right.
So
yeah,
can we switch over now, Tina?
Yeah, I'm going to
Thank you
switch
very
that
much
off.
for your great presentation. Right. So are we here? So can you see my slide?
Not yet. Yeah, now we can.
Is there? Perfect. So thank you, Dr. Tina, for your very comprehensive and very practical presentations. Right. So now I'm gonna go ahead. Right. So today's debate question. This is the last session of our today's meeting. We will try to pick up something which we can debate and discuss about it. Today we're gonna talk about physiologic validity of the DICE, and here I'm gonna ask Professor Hisham to lead this session. But beforehand, let's do the pool questions about physiological validity of the DICE. Right. So can you have those questions, please? Meanwhile, you can just scroll down and answer all these 4 questions. Meanwhile, I'm just going to say that it's very fortunate for us. Dr. Simab Sheikh from Pune is also with us today. And I just unmute him. So,
thank you, Shailesh. Good
thank you.
evening to
Happy
every
to
one of
hear your
y'all.
voice, Professor.
Lovely. Good evening to all of y'all, Peter, Tina, everyone. And I'm just going to try and reply to your questions first, then we'll talk.
These are some really lovely questions. I can't wait for the discussion ahead.
I think we wait for 10 more seconds. Right. So DICE accurately reflects natural sleep in most patients. The biggest limitation of DICE is perfect replication of natural sleep is necessary for DICE, and DICE similarly to real sleep is sufficient for clinical decision making. Really thankful to Professor Hisham.
My pleasure. We work together.
Thank you. So can we have the whole results, please? Right. Yes. So Professor Hisham, so please go ahead. How do you feel about this input?
So the first question, which says DICE accurately reflects natural sleep in most patients, and interestingly enough, 36%, which is like more than a third of the candidates here, thinks actually it is like a reflection of natural sleep. And it will be very interesting to see the sample answered by our panelists here. Do you want to have my answer first, Shailesh?
Yes, absolutely.
Yeah. So the question is that we all know that it's the best resemblance we have. It's imperfect, but it's the best available tool until today. I think the best tool is going to be in the market, I hope, within the coming years, is what we have, like an ambulatory, home-based, wearable nasal endoscope. The patient would wear, you give it to him home, he wears it, and then it shows you the whole thing, which is taking place dynamically with like a natural sleep rather than a pharmacologically like created one. Definitely DICE lacks a lot. If we come to speak, it's like a snapshot of an episode and part of an artificial sleep. This is one. Two, at great deal of times, definitely we don't have the REM sleep, which is very important, especially in REM sleep predominant obstructive sleep apnea. If it is positional, then that's another story. Also, it's only a single episode. We lack the night-to-night variations that might take place even with an ordinary obstructive sleep apnea. We don't have the arousal effects. So it's a lot of things that would make it beyond optimal, but definitely it's the best. And if we compare it to our its counterpart, which is like awake endoscopy that we carry in the clinic, then definitely it's a big win to go and proceed for DICE. Well, shall we take opinions from our colleagues here, or shall we proceed with the second question?
We can proceed with the second one, then we'll get the common comment.
Definitely. Yeah, definitely. So the second question, the biggest limitation of DICE is, but I can't see the whole thing. I can see only sedation there. Can we scroll it up kindly so that I can see all the answers?
I can see all the answers. You can't see Professor here? You can scroll.
No, I can't see the. Oh, sorry. I just noticed that. My apologies. It's my mistake. So now the biggest limitation of DICE is, and then the biggest thing here is saying lack of REM sleep. And myself, yeah, it's the highest here. Like 50% of the candidates thought so. See, now we have two important like limitations that need standardization when it comes to DICE. The first one is the scoring system, and the second one is the sedation. Lack of REM sleep definitely is important, but then it will be more important if you've got like a polysomnogram phenotype that would shows you that it's a REM sleep predominant. So I would take that off seriously. I would stick here to sedation, because I think that's whereby we try to catch that window whereby a patient is almost nearby to a natural sleep. He's not too deep nor too superficial. So shall we proceed for the third?
Yes.
Yeah, right. So the third question says, is perfect replication of natural event necessary for DICE? So now the question, and it says equivocal, which not bad answer. I think it's an escape of the reality. So to me, well, it's not perfect replication, but the issue whether or not it would give us like a clinically applied targeted therapy, whether it's surgical or non-surgical. So in a way, it's not perfect replication, but it's the best so far. So I would say, no, it's not, but it's the best so far.
Right, so last question to go.
And the last question says, DICE similarity to real sleep is sufficient for clinical decision-making? And here it says depends on the case and setting. I would seriously go for that. Actually, I like it because definitely it depends. Because as we did now today, like we had that patient we discussed, and then it wasn't only the DICE that we took in consideration. We're discussing all sorts of aspects. Even we went all the way to see the psychology of the patient and whether or not he's got to be seen by a psychologist or a psychiatrist, maybe. So yeah, so we are done with the questions. So I don't know. Shall we discuss them?
Can we have
among ourselves?
Yeah. Can we have a quick comments from our panelists? One or two quick comments about our poll about related to the DICE and physiologic aspects of DICE. Any comment, Professor Peter, Dr. Ahmad?
Yeah.
Anyone?
I have a couple of quick comments. I would say, it truly is the best tool that we have available, but it's very important to understand what is it used for. It's not a diagnostic tool. It's more of a prognostic tool. It doesn't tell you what to operate on, but rather whether or not you should be operating in the first place. And I think that distinction is very important because, as like some practices differ, like for example in Oman, like with Professor Muhammad, I don't necessarily think that the right thing is to dice everybody and have everybody have that prescribed treatment. I think dice in and of itself should be personalized, should be individualized according to the patient. So in my mind, there are maybe a handful of indications for drug-induced sleep endoscopy. I would typically use it for people who've had, upper airway surgery before, to assess candidacy for upper airway stimulation, using it as a planning tool, maybe for maxillomandibular advancement, just to have a better idea of how to plan the movement of the maxillomandibular complex. I would also use it in cases of CPAP failure or MAD titration, just like with Dr. Tina, having that additional visual idea of like how the airway reacts is important with these tools. So I'd be very careful, honestly, with that. And then, for patients with hypopharyngeal obstruction, I would say, which are, a special type of patients, the selection of the pharmacological agent matters greatly. So if you can find an anesthetist who is comfortable with dexmedetomidine or Persidex, that would be ideal. But relying on propofol or midazolam can potentially lead to consequences like that are untoward. So like unnecessary surgeries or surgeries that are complicated, particularly for the hypopharyngeal structures.
Right. So I think
Prof. Ahmed, allow me, Shailesh. It's very interesting because the discussion is very hot and I like it. Prof. Ahmed, just kindly elaborate more, because you said you wouldn't do DICE for every patient. So what sort of patients are we talking about here? Is it like those simple snoring or those with definite obstructive sleep apnea? So just to see. The reason why I'm asking, now, if a surgeon operates on a parotid and he gets facial palsy without using a monitor, then he's going to be litigated, right? If he does FIS and he doesn't have recording and it was like a really challenging case, then also he can be caught. So here, I think also if we operate on patients and then we get litigated, but we are supported by a DICE, then also that could be something on our side.
Well, that's what I meant. So there's a misunderstanding of what a DICE is. With those examples, like for example, a nerve monitor or the navigation system, they don't lead to erroneous information because
very true.
That there's a very objective result that you're using it for. But for drug-induced sleep endoscopy, when you use it as a selection tool to tell you what to operate on, it's not as accurate as we think it is, because number one, we don't have normative data from large populations as to what a normal DICE looks like, right? So like if I had a DICE tomorrow and I don't have sleep apnea, I'm pretty sure you're going to find obstruction in my airway, right? And then the other aspect that is also important as it relates to this is that a lot of people do it before even having a sleep study. So you need to have multiple data points. You can't really rely on just the visual inspection of what a DICE shows you. And then, when it comes to the validity and the reliability of the test, it is fairly reliable, meaning that you can really reproduce the results if you have people like high volume, operators, whether from the anesthesia side or from the surgeon side. But, even among experts, inter-rater variability remains at 60-70%, particularly for hypopharyngeal structures, meaning that you're an expert surgeon, I'm a less experienced surgeon, yet 60% of the time we are going to have very different results in terms of like how we evaluate the airway.
True.
Professor Hisham, Shailesh, with your permission, did I just take that question that Hisham has put forward?
Yes, please, Dr. Simha.
Yeah, definitely.
Hisham, that was a good question, but there is a certain thing about the medical legal aspect that you're talking about, that if you have even an awake flexible scopy in a supine position, which is well recorded, after you have done a sleep study, right? Then that suffices for you to be able to know what areas you're going to be tackling. And not doing a DICE before you do any kind of, say, palatal surgery or nose surgery is definitely not a medical legal issue attracting litigation, because it all depends on how you kind of word it. So if you're doing it for airway obstruction, it really doesn't matter. If you say you're doing sleep surgery, then that's where they ask you to have a sleep study before that, that you're doing it for a sleep study. And just as an additional part of this, I mean, this is for everybody listening in. The International JLO of April 2026, finally, after almost 6 years of what I've been talking about to everybody, that don't overdo your DICE, don't overhype your DICE. DICE is just any other investigation. It is not something that you cannot do without. So we've published data. My paper has been accepted without any reviews, I mean, without any changes, where we've given in data for over 180 or 173 patients, where I did a flexible awake scopy first, made an impression, made documentation, decided on the plan of surgery. And in those same very patients, we went ahead and did a DICE, recorded our observations, and then decided on the mode of action that we were to do. And we got a very statistically significant figure to say that it really did not change our plan of action as far as the palate is concerned. Please understand my words very clearly. I'm talking till the level of the palate. Yes, the only place that DICE made a difference to decision making was at tongue base and epiglottis level. But till the level of the palate, it made no difference. I would really recommend, if all of y'all could just get hold of that article, I will myself post it to Shailesh and maybe he could send it across to all of y'all. But do read that.
Yeah.
Okay? And that's where the medical
Prof,
legal part doesn't really come in that much, Hisham.
Prof. Simab, you said the palate. Does this include the oropharynx as well or not? Because that's something that DICE can be of help. Oh, okay, that's together. Okay.
Yeah, oropharynx and palate is together, because like what even Shailesh mentioned, I heard him say that whenever he removes the tonsils, he will go ahead and do a simple sling, at least onto the uvula or the palate, right? So when you do that as a workhorse, so in the earlier days, the workhorse was the barbed pharyngoplasty. Now it has become just the lateral pharyngoplasty with the sling on the palate. These have become the workhorse procedures. So when you have a clear-cut workhorse that you're going to use to target the palate, then till the palate level, and I repeat again, till the palate level, you definitely may not need a DICE as a die-hard must do before sleep surgery.
I think what I understand, Professor, I think this is a very interesting topic, and I think we should have this put up, in a subsequent meeting.
I will definitely send you that article, Shailesh. Very soon.
Absolutely.
Tomorrow I'll send you that article.
Dr. Shailesh, but one more thing before we finish this discussion. For me, I'm operating on the patient anyhow, right? Let's assume that my plan, as Prof. Simab said, he's gonna do like an awake endoscopy, and from there he decided that this patient needs like palatoplasty and tonsils, more or less, and pharyngoplasty. But then, don't I need the DICE done at the same time, at least to address my future plans in case the whole thing failed?
So, Hisham, what happens is when you're doing a multi-staged approach, right? When you finish your palate, the entire dynamics of the airway is going to change. So, if you did the DICE before you did the palate, and if you did a DICE after you did the palate, your entire airway dynamics would change and you would see a different picture altogether at a later date. So if you are not approaching a patient in a single stage procedure, So what you're saying is absolutely right. I agree with you, but that applies only when you're doing a single staged multi-level procedure. But most of the times when we are addressing a multi-staged procedures, then till the time that you reach and finish the palate stage, you may not need to do the dice. But I do agree with you that if you are going to do a single level, let's say you have an outstation patient who's come to you and he's not able to come back again and again, and you're going to do it the nose, the palate, the tongue base, and maybe even the epiglottis all in one stage, then definitely yes, you need to do a dice at that time first.
I think I can conclude this quick debate. I can say that, the dice itself have a lot of dooms, and there is no standard protocol. There is no standardization of the anesthesia. It has a lot of variability in terms of the surgeon, physician, experience, all that matters. And and these are all even the same dice performed by me, recorded by me, it will be read by the other physician very differently in terms of parameters, recording. I think there are so many dooms are there, and that's why the debates keep going on. So I think we can go ahead further with your all permission.
Absolutely.
Perfect.
Yeah. So quickly, I think Dr. Ahmed Al Said have some comment about propofol, dexamethasone, and midazolam. All right. So I think we can, Dr. Hisham, do you want to say something about this, or we can proceed further? Any quick comment?
Just a quick thing. I mean, the slide speaks for itself, so I'm not going to take time here. I think most of us are more comfortable with propofol because of the rapid action, rapid recovery, and also titratable, so you can control it in a way. The bad things about it is the airway collapse and respiratory depression. I think, and then the rest goes on, but I think it's not only the choice of the sedative, and it's the degree of sedation that we are inflicting on this patient, because we are between the two extremes. Either the sedation is light and it's not representable, or it's very deep that will create artificial collapse. So you want to be really in the middle, within that window of proper sedation that will resemble sleep, natural sleep. Yeah.
Right. So just quick add-on to the participant. If they want to ask any question, they can drop it at the chat. Anyway, we are running out of time, but we definitely take a couple of questions. All right. I'm gonna move to the next slide. Right. So as always, I share a few upcoming sleep meetings. So please participant, put some questions if you have any. So we can definitely address those. So I think a lot of my colleague and panelists are going to Istanbul for this Congress for sure. And of course, we're gonna meet at a global sleep surgery. It's gonna be a big event happening in Coimbatore, September. In October, we are planning to organize Myoto academic meeting. And in Los Angeles, there is a ISSS meeting happening in October 15, 16. And along with this Myoto, we will have this cadaver dissection course. I can say to all the participants and of course the panelists knows this is something we again put it like this kind of a discussion in this sleep cadaver dissection course. We're gonna put it a lot of live dice findings, and we try to correlate. We try to discuss in depth about the management practical aspects, what we are discussing for last 1 hour, 1.5 hours. Those who like interested to know more about it, please drop me a message. I'm happy to help you with that. So, any comment or anything from Professor Peter or anything, so we can conclude our today's meeting.
Shailesh, I've already sent you and Tina and Hesham the article.
Thank you.
Please go through it and send it out to your
Definitely.
colleagues.
Thank you.
Peter also, I've sent it to you, Peter.
Dr. Peters just
Thanks a
left,
lot.
but I want to say, Dr.
Okay.
Shailesh, thank you. This was such an amazing discourse. You picked a really interesting case. And, I look forward to more discussions on, especially what Dr. Hisham has just started for us about this.
All right. So I think we
Thank you,
can
Tina.
end up with the today's meeting. So, I'd like to thanks all my faculty members and the panelists, those who are all the way as a backbone and giving their valuable input. And I would like to also express my sincere gratitude to Mr. Edward and his entire marketing team and event team from the Tarabishi Stamberger Center. They help us really. They work hard behind the screen to make this event successful. And nevertheless, I would like to thank Dr. Professor Muaz, and he's a founder of TSEI, and Dr. Iyad is the CEO, for his guidance and support. And most importantly, my participants, those who are here to join us today, I hope you guys all enjoy this discussion. I hope so you will join us for future Gulf Sleependo Lounge meeting. I hope so it is more practical, educational, and I think you get some message from this meeting in a clinical relevant way. Thank you very much, everyone, again. Thank you and have a wonderful evening. Stay safe and keep
You too.
advancing sleep medicine. Thank you.
Bye-bye.
Thank you.
Thank
Good
you.
night.
Good night.
Thank you.
Thank
Bye-bye.
you, everyone.
Good night.
Thank you,
Bye-bye.
sir. Thank you all.
Thank you.
Very much.